Good morning. Welcome back to Favaloro Foundation University Hospital. We are in the lab number 4. On my right side is Dr. Carlos Fava, Dr. Juan as a fellow, Erica as our technician, Nora our nurse. Gabriel is a special product from Medtronic. Dr. Cotto is our anesthesiologist, and Dr. Eugenia is going to do the echo that she's going to show to you in a few minutes. In the control room, Hernana and Gustavo as the technicians, and Dr. Rodriguez is going to translate or transcript the question from the audience for us. Let's introduce these first patients for this morning. Let's go with the first slide. Perfect. This is next. So she's an 82-year-old female. She presented with a syncope episode, at least 2 episodes. She has a history of hypertension and severe obesity. She is not fragile and not fertile according to our clinicians' evaluations. Next. On the ECG, she has a normal sinus rhythm, but with a PQ in the borderline with 200 milliseconds. The QRS complex is 80 seconds on duration with the left anterior fascicular hemiblock. So the blood test is practically normal with the 100,000 platelets count. The body mass index is 33. She is really short and obese. The echo Doppler done in another hospital showed severe left ventricular ejection fraction of 55 with significant hypertrophy with severe stenosis, and a tricuspid valve with an area of 0.7 and gradient of 79 and 46 with a Vmax of 4.2 millimeter per second. Coronary angiography done also in another place showed, in another center showed the left main stenosis with significant compromise of LAD and left circumflex ostiums. Let's see the next. So this is the ACG, where she also has some supraventricular ectopics with this PQ of 200 milliseconds and the left anterior fascicular hemiblock. Next. This is the angiography. The right coronary artery is dominant. It's a big artery with a mild lesion in the proximal segment. Probably is 30 or 40% of stenosis at that level. Next. And here we can observe significant calcification on the distal left main and also the proximal LAD and on the proximal circ. In this AP view, you can observe distally, immediately after this huge diagonal branch, there is a significant and calcified stenosis in the middle segment of the LAD. Next. So here on the spider view, we can observe a little bit better both ostium compromised with this distal lesion on the left main that is better observed on the left panel, and this left anterior oblique inclination. Next. So we did the CT scan evaluation according to the presentation and the diagnosis of the severe aortic stenosis. This is the core lab evaluation from Medtronic. This is 21 millimeters and 25, almost 26 in diameter, with a mean diameter of 23.6, with a perimeter of 75 almost, with an area of 440 square millimeters. Next. The ascending aorta is normal, 33 millimeters, and we can observe there is a valve calcification, but not too much, especially on the free borders of the 3 leaflets. Next. On the LVOT is a little bit smaller with 20 and 25 millimeters in diameter, elliptical. The valve configuration is a tricuspid valve with 3 sinus with a diameter of about 30 millimeters. For all the sinus. The sinotubular junctions, there is small calcification about the right coronary cusp with a diameter of 26, 30, and 28 in the 3 measurements that were done there. Next. Regarding the sinus height, especially for the left coronary ostium and the right coronary ostium, the height is almost okay, or it's okay. 12 millimeters for the left coronary ostiums and 16 millimeters for the right coronary ostium. The non-coronary cusp height is 20 millimeters. Next. So this is the aorta. There is some calcification in the abdominal aorta and on the descending thoracic aorta, but not too much. And some calcification also distally to the left subclavian with an angulation of the annulus of 51 degrees, the angulation of the annulus regarding the left ventricle. Next. So this is the implanter's view on the right and left cusp overlap view, 31 angulation on the right oblique, and in a caudal inclination of 28. It's going to be a little bit uncomfortable, but I think we can deal with this projection. Next. So these are the vascular axes. The right iliac artery is normal, 9 millimeters in the common, 6.5 on the external. And the right femoral artery is 7 millimeters without significant calcification there. Next. This is the left iliac artery, which is almost the same, 9 millimeters in the common, 6 and 7 diameter for the external. And the left femoral, common femoral artery is about 7 millimeters in diameter, also without significant calcification. The only problem we had for the puncture is that she is too short and both femoral arteries are quite deep, not so easy to find with the echo imaging that we did for the puncture. Next. So these are the both iliac arteries configurations, strides, not significant angulations, and not stenosis. Next. So in summary, she's an 82-year-old female, quite obese, with a morbid obesity actually, with severe aortic stenosis and with the left main and compromising left anterior descending artery and left circumflex stenosis. The STS score for mortality was calculated on 9% with a morbid mortality of 32%. The syntax score 1 is 21, and the syntax score 2 is 40% at 4 year with a 4-year mortality of 15%. So she was presented and discussed within the heart team, and the suggestion was to do PCA and then in a stage procedure, a TAVI procedure. So next. So we have already done the PCI that I will show you, and we are planned today to do the TAVI through a percutaneous femoral access. We are going to use a self-expandable device in this patient. We are going to use the Evolut device. Next. So this is the PCI. So we did by radial approach with a 6 French sheath, and as you can observe there, this is a significant calcification of the distal left main and both ostiums. Next. So here is better observe this lesion distally to the diagonal, but immediately after the diagonal. So we used both wires, one for the LAD and one for the diagonal. We plan to deal with these 2 bifurcations in, I would say, almost in a separate procedure. We did the distal bifurcation first. We use provisional stenting for the distal bifurcation on the LAD and the diagonal because it was a Medina 010. So no significant compromise of the ostium of the diagonal. So after predilatation, we went with this DES 3.0 by 23 millimeters. Next, we always inflate at 14 or 16 or something like this. We always use high pressure. Next, so as you can observe there was acceptable outcome. Then we post-dilate and we use a pot and then kissing stent with a 3.0 for the LAD and 2.5 by 20 for the diagonal. And this is the final outcome, which was, I think, more than acceptable. So next. So after this bifurcation was solved, we decided to go for the left main bifurcation. In this case, we decided to use decay crash technique. We went with the LAD predilatation first, then the circ, and then we went with the stent for the circ. We used for predilatation the same balloon that we used distally, the 3.0 for the left main and LAD artery. Next. So there is the positioning of the stent for the left circumflex. It's a 3.0 by 23 with a little protrusion into the distal left main. On the right of the panel, you can observe a good angiographic outcome on the ostium of the circ. And also, we cover a mild or moderate lesion, which was distally. We didn't want to leave this lesion in the outflow of this stent. Next. So we crashed the stent with a 3.0 balloon, and then with a 3.5, and then we did the first kissing using 3 by 3.0 on the diagonal and 2.5 on the circ. And then we use 2 3.0 balloon. I didn't put all the images because it's not going to be a little bit long. It's a very complex PCI, as you can observe there. And then Proxima, next. We went with the stent for the LAD. We went to left cranial angulation to check the proximal position of the stent, trying to cover in the ostium. Not protruding too much because we are going to do the TAVI after this procedure. And there was a minimal overlapping between the stent from the left main and the stent that we implanted on the LAD. This is a 4.0 balloon, excuse me, a DES, and 23 in length. Next. So I retrieved the wire from the circ. We did the angio after dilatation. I left the wire there to protect the wire. So I can use the same wire for recrossing to the circ, as you can observe there. And then we went for a kissing balloon, 3.0 by 15 to the circ and 4.0, 23 to the LAD. And then we did a pot with a 4.5 balloon for the left main. Next. And this is the final angio. As you can observe, this is a very nice outcome, not only on the left main, but also in both ostiums. Both arteries looks really well. So we finished the procedure with IVUS. I don't have the images, but the IVUS was done. Next. And this is, I think, the final angio for the PCI that we did almost 6 weeks ago, Carlos, no?
Yes.
Okay.
6 weeks ago.
Next. So for today, we have to use the Evolut. Click, please. And according to the diameter, which is 74, is borderline. But we have discussed with Gabriel, and we decided to choose the 29 device. So next, we are ready to be back here in the lab. And we have done here contralateral access. I was here in Dimitri speaking from Sao Paulo that most of the cases they use the radial approach. We still use the contralateral access, especially in obese patients, to check if we don't have bleeding in the main access, and then also to solve if we have the bleeding, because from radial, I know it's safer, but if you have to fix the problem, you have to do the puncture and then a heparinization or under emergency. And this is why there is a little discordancy between different teams. Some use still contralateral, some from below, another from radial. Anyway, I think everything is okay. And we have introduced an 11 French sheet here to wait during the 30 minutes we were waiting, because we are a little bit anxious for preparations, and we start a little bit earlier. And Eugenia did the echo, and probably she can share with you the images and comment on that. Can we show the echo, please? Let's see the echo. Perfect. So,
Oh,
Kenya.
okay. Hi, good morning, everyone. Well, as it was mentioned before, the patient has a preserved left ventricular ejection fraction with an important concentric hypertrophy. And as you can see in this loop, that severe hypertrophy causes, as you can see in the color Doppler, an intraventricular gradient that was measured in 52. And what you can also see is an important calcification of the aortic valve that causes a severe aortic stenosis with a peak velocity of 4.5 and a mean gradient of 52. And that causes an estimated aortic valve area of 0.6 centimeters. So it's a really severe aortic stenosis. And what's also important to say is that the patient has no pericardial effusion.
And also we have a ventricular gradient. Is that correct?
Yes, an intraventricular gradient I can show you here at about 52 in basal conditions.
Okay, so it's something that we have to bear in mind for the procedure, because probably when we measure the post-procedural gradient, we will find some gradient. It's important to share also for the follow-up of the patient. So now I think we have the valve ready? Could you prepare, please? So what we are going to do now is over this catheter we exchange by an unplugged wire, and we are going to introduce the central sheath, this 14 sheath. We only have one prog-line, as I have already mentioned. And then we will probably use a complementary angioseal or something like this if we have some bleeding. So the other comment, other two additional comments. We have deployed wire for pacing on the right ventricle. Anyone here? Because these previous conduction disturbances, although it's not that severe, but probably we can worsening. So that's why we decided to put the pacemaker on the right ventricle for the procedure instead of pacing on the left side as we usually use for patients with the normal conduction system. So I am introducing the 14. She is very short. And the other comment would be that according to this not so important calcification, we can try to go without pre-dilatation. So Gabriel is preparing the valve. So we are going to cross the ventricle. We will check the valve, and we are going to do the angio for the working position, and then we are going to deploy the valve without pre-dilatation. Just as a comment regarding pre-dilatation, here we work closely with Dr. Eberhard Grube at the beginning of the experience because we thought that without pre-dilatation, we will probably have a lower stroke rate. However, this theory beyond our publication was not confirmed. As you know, it's also difficult to show some benefits regarding stroke, even using distal cerebral protection devices. So now pre-dilatation is left to operators' discretion. So in cases without significant calcification, we try not to use it. I'm speaking about self-expandable valves. For balloon expandable valves, it's probably less common of the use of pre-dilatation. This is a case of that for sure, if we use a balloon expandable valve, we are going to go without pre-dilatation. Once again, you can see that if you persist for some seconds or minutes, you can cross with the J-wire and the pigtail. You can position in the pigtail distally with an upper orientation like this. So you are sure you are protected to introduce the Confida wire. So now I'm going to flash. Just as a comment, sorry, before that, we have Dr. Rodriguez on the control room, and he can answer or transcribe to us the question from the audience. So I invite to everybody to ask questions, to help us with the procedure, or comment, critics, suggestion, or whatever is welcome. So meanwhile, I would say that one of the comments I was about to say is we were talking in the morning with Dr. Fava, who is on my right side. He was reviewing our 2 years data, last 2 year data with 200 procedures with self-expandable valves using cusp overlap implantation technique. And we observed that patients without any conduction disturbances or previous conduction disturbances will have a permanent pacemaker rate of 3%. But in patients with conduction disturbances, the permanent pacemaker implantation rate is 21. Is that correct, Carl?
Yes, yeah. Correct.
Okay, 21. So now we are going to separate or to analyze. We'll try to find some predictors, but I think it's an interesting data because in patients that you want to discharge earlier, probably if we think in the future in a program of same-day discharge, the presence of previous conduction disturbances would be probably an important marker that would help operators to decide how to handle or manage these patients. So now we are at 32, 27. I think it's almost okay. Un poquito más caudal. Uno más. Okay. Okay. It is supposed to be here. Let's check. I think the projection is okay. We can see very nice left main LAD and circumflex. The stent looks perfect. So pone AP. So we will check the valve first, and then we are going to cross with the Confida. So Gabriel is bringing the valve. Cover the face of the patient, please. Cubrir la cara. So to prevent any kind of contamination and to show the patient faces. So we observe here very perfectly when we rotate the device. Both pedals are there. So we have introduced or reshaped the wire as always. Here on my left hand, as you can observe, I downgraded the loop, the distal loop of the Confida, and I introduced this bend near to the distal tip, which is quite 15 or 20 centimeters. That it would help me to retrieve the nose cone of the delivery system, especially when we have a significant angulation or when you have a heavy calcification on the non-coronary cusp, where usually the nose cone is positioning after delivery. So, vamos de vuelta, sí. Subile un poquito la presión, Coto, porque ahora vamos a ir con la válvula. So I imagine anesthesiology. Yeah.
Dr. Mendes?
Yes.
Do you hear me?
Yes, perfect.
Yes, Rahil Begoswami asked you if you use a singular proglide or precloser.
Oh, this is an interesting point, Calito. No, hold it here. So yes, for normal arteries we use one, but if we have disease or something that could, suggest us that we might have complication, we would rather use two. But in this case, with the normal artery, we use one. I will show you when we finish that we try to close the proglide using a 6 French sheath. So if we have a complete closing, okay, we stop there. If we have a bleeding, we introduce an angioseal. Or yesterday, we did a case extremely interesting because we have a tight stenosis and severe calcification of the common femoral artery. And we went a little bit higher, actually in the very top of the femoral head, above this stenosis. But according to the calcification that was presented a little bit below, we decided to go with the old ProStar, with the stronger needles. So let me zoom a little bit. I try. Okay, I think we are perfect there. So hacemos un test. Ok, yo te voy a decir marcapaso 120. Ok, vamos. Let's go. So I'm gonna try to go higher here because we have the angulation, but slowly, very slowly. But we have a good positioning of the delivery system. It's a position against the external wall. 120. So we were very careful with the pacing. Espera un poquito. Yes. Okay, let's go. Because the blood pressure goes down with the pacing, probably due to her hypertrophy. So decrease pacing very slowly. Okay, a 50. So you can observe on the hemodynamic probably how the blood pressure is recovered when the pacing is stopped. Probably because this ventricular pacing is not well tolerated due to her hypertrophy. Let's see here. I think the position is acceptable. Carlos, do you like it?
Yeah, I think it's.
And you see that despite the angulation of the annulus, the valve is not, I mean, it's very well positioned in the center. I wouldn't say against the external wall, but in the center, which is okay. That is going to be not too much movement, hopefully, after the final delivery. Let's check on the left oblique view. So let's take the parallax out. Let me push a little bit, Carlos, here. Here seems to be higher. Let's check, test. So here it's important to concentrate on the left cusp. So we have a good contact there, and it's at 1 or 2 millimeters. So we don't have to pay too much attention on the non-coronary cusp, where the pigtail is now. Let's move to the... ¿Volvemos? Let's check here again if we are comfortable here, or we decided to repositioning and go a little bit lower.
No,
I think the position is okay. We don't have too much calcium, but I think the position is okay. Do you agree, Gabriel? So, okay. So let's go slowly. Marcapaso 120. Okay. So I am gonna pull the wire a little bit to prevent the pushing. The delivery is now against the external wall. Test. Okay. Okay, final delivery that I push a little bit. Okay, so you see we have a paddle there that is not completely released. Let me push the system, and now it's completely released. So saca el zoom, give me the unplugged wire. So before retrieving the delivery system, I like to retrieve the pigtail, just in case I have to push a little bit. if I have problem to retrieve it. So now I am pushing the unplugged wire as much as I can. So the wire push the pigtail out. I am not pulling the pigtail, just pushing the wire. Now the pigtail is out. Let me do final movement. So you can observe there how much angulated the aorta is. And using all these tips and tricks, I think we can have a good position. So now is a critical step. I am absolutely convinced that both pedals are free. I'm gonna pull. So the device is out. I had to centralize the nose cone as much as I can. There, using my loop. You see, it's working. And now I am out. Okay. So this configuration, I will make Cine. It's usually a configuration that the position is okay for the overlapping of the cusp. I will closing. And we are going to introduce, saca un poquito de caudal, así estamos más cómodos. And Eugenia can check.
Yes.
So while we are reintroducing the sheet, Eugenia is slowly is gonna check how the echo or what the echo is showing to us. So the blood pressure is okay. You see hemodynamic there. I still have the wire inside. Well, the only problem is okay. So let's take your time, do all the measurements, measure the intraventricular gradient, and share with the audience your findings.
Okay.
So now we have to decide whether we have to post-dilate or no. The positioning for the delivery, I think it was great. If we had to post-dilate, it's a little bit higher. We could, or we can. But it's not ideal, especially when you don't have too much calcium.
Okay, so the gradients have significantly decreased. The mean gradient of the aortic valve is 7 with a peak velocity of 2.08, and the interventricular gradient is about 10 or 7 millimeters, has also decreased. And we can see a mild leak, but just mild, and there's no evidence of pericardial effusion.
Where do you find this leak?
I'll show
Sorry,
you.
Dr. Mendes,
Yeah.
the echo is not show.
Okay.
Oh, yes. Oh, now,
Yeah.
yes.
Yeah.
Is there, and it's near the septum, the interventricular septum, right?
Perfect.
But it's mild, you know, it's this one over
Could you
here.
show the gradients again? Because
Yes.
It was my fault. I didn't ask Philippe to show the echo.
This is the aortic valvular gradient. 7 is the mean gradient. And the interventricular gradient is almost you cannot see it because it has also decreased. And as you can see here, this dagger shape 6 of interventricular gradient. And this was the previous one.
Let me ask you a question. I'm an old guy. How this intraventricular gradient decrease if we only solve the valve?
Well, the hypertrophy is something that it's usually a compensatory mechanism. So when you open the valve, if you have the right preload, you could see that the gradient has decreased.
Okay.
Because of you solve the pulse load, meaning that you can see that decrease in the gradient.
The there would be any influence of the fluid that we gave to the patient?
Yes, because it's the gaining in the preload that causes that the
Okay.
solving the aortic stenosis would decrease the interventricular gradient because of the preload also.
Okay, here we have a good view on the AP view, Soltame, because the parallax is out. And maybe we can inject here to check if we have regurgitation according to the ancho. And you see that it looks a little bit deeper than it was delivered. Show me on the, but this is not the projection we used to work, or the working position, sorry. It's a, so in a way, what we are showing is how important is the pre-procedural CT scan evaluation to find the working position. You see that here on the non-coronary cusp, the valve is at 3 or 4. On the left coronary cusp, it's probably at 6. When the valve moves a little bit more to the external part, so it went down a little bit. But anyway, we don't have too much leak. And also we have a perfect cusp alignment. You can observe how free is the filling of the left main there. So we haven't discussed about that during the implantation, but here is a good demonstration. So let's let's check our gradient, but of course we believe on Eugenia's measurements. Another finding here is we cannot define very precisely where is the deepest part of the non-coronary cusp, because it's almost closed. Probably 20% of the cusp is closed with the valve. Anyway, it's a good position if we have to post-dilate. And also, it's important to follow the recommendations when you are using cusp overlap view. Don't pay too much attention to the right or to the non-coronary cusp when you are going to the left oblique, because here the valve was okay. It was contacting the left cusp. The depth was probably 3 or 4, and actually after the movement, it finished probably 6 millimeters below the left coronary cusp. And additionally, if for any reason, even in our case, if we have decided to recapture and deliver again, you have to remember to go back to the cusp overlap view, because if you do it on the left view, actually you are going to our old technique. And remember that our old technique has a higher permanent pacemaker implantation rate. Here you have the hemodynamic in agreement with Eugenia's measurements. We almost don't have a flash gradient. Diastolic is okay. The leak is minimal. Okay, so let's 0 for both. And the patient is a little bit tachycardic at 90, but the conduction is almost the same. No? Okay, here we have a better hemodynamic evaluation. So diastolic is 53, the index is probably 30 or something like this, because it's quite similar to the case that we did yesterday. The notch, diastolic notch on the curve of the aorta, it's okay. So I think we are done. We have to close the groin to pull the pigtail. Maybe Eugenia can do the final measurements without anything inside the valve, and we can close her. Yeah, and I will show you to the doctor who was asking me about how many proglides we were using, how we are going to close here and use the 20 minutes we have. So it's something interesting, because now podemos tener un poco de luz. Interesting, because doing believe me, that probably we spend in lab 1 hour and a half doing her PCI. And here, probably the procedure lasts no more than 20 minutes. So in a way, what we are trying to show you is how much predictable has become TAVI procedures in comparison with complex PCI, which is still remain as a significant job because predilatation, sometimes you have complex lesion, non-dilatable lesion, you have to prepare the plaque, the IBUS pre, IBUS post, kissing, pod, and so on. And here it's just crossing, deploy the valve. In this case, we are done. The patient is almost ready to go home. That's good because this is, in a way, showing how is TAVI doing and why it has overcome aortic valve replacement in many places around the world. Over here. So now I'm going to retrieve the sheath. So, and Carlos is going to hold the groin, and we are going to introduce the 6 French, just in case we have to cross with the angioceal. The femoral artery is very deep here because of this body configuration of this patient. So let me see. We have this here and here. Okay, don't do any mistake. This is the problem when you only have one ProLife. You don't have any backup. So as you can observe, we still have some oozing. So I think, considering that this is the patient and then under aggressive antiplatelet therapy, we cannot revert the heparinization due to the very recent stent in a very complex procedure. I'm going to use the 8 French angioceal. Let's prepare the angioceal. Sí. Carlos is going to hold the groin. I'm going to introduce the angioceal. After the angioceal delivery, I try to tie the knot a little bit more. If we have some oozing, we can go with the contralateral balloon. Here I have resistance to enter, and now I'm in. Okay, I have some back blood flow. I think vascular access is still an important issue on the TAVI procedure. So wait a second. So I'm gonna pull. Carlos is gonna cut. Give me the okay. I'm gonna cut the angioceal there. And now be careful. I'm gonna close a little bit more here. Tie the knot. It's so deep. Okay. And now we can do a test, a contralateral test. Yeah, let's inject a little bit. Okay. So now we have the final test to check that everything is okay. Hopefully I have answered the question of our colleague asked from the audience. So I'm going to inject. Patient is awake. So she's moving a little bit. I think it's perfect. So now we are going to cut the thread. We're going to suture here the skin. I'm going to pull everything out, and Carlos is going to finish the procedure. I'm going to pull first the wire and then the catheter.
Dr. Mendes.
Sí.
Dr. Goswami asked you did you advance the ProGlide knot with the 6 French sheet in place?
Yes, absolutely. To keep in some space for entering the ancho seal, because if you, in my opinion, if you tight very, very strongly the ProGlide, and then you have to advance the ancho seal, you have to make a little bit, force or to push a little bit harder, and you can destroy the suture. So it's better to leave a space in the center where you can cross with the ancho seal, then you tight against the ancho seal again. And when you use the ancho seal and the ancho seal is finally delivered, you can go a little bit deeper with the suture of the ProGlide. I don't know if I was clear. Trying to sum up is leave a small hole to enter very easily, gently with the ancho seal, not trying to push too hard. If you have to push, I would recommend to rotate clockwise and counterclockwise, but not pushing too hard to prevent destroying the suture of the ancho seal, because remember, it's the only one you have. If you destroy the suture, the only solution you have is to go contralateral, inflate the balloon, and put a stiffer wire, go with the 6 or 7 French contralateral sheaths, and to deploy a cover stent if it is recommended, or surgery, which is going to be the other possible solution. So, Kenya, any additional finding, any comments?
I measured again the intraventricular gradient, but with color Doppler and also with the spectrum, we can see that it decreased significantly. The intraventricular gradient is 8, and the mean gradient of the transaortic valve is 7, and there's no pericardial effusion. So,
okay, so I thank to the team in this room. Thank you, Carlos. Thank you to everybody. Thank you, Kenya. I'm going to take some minutes to move to the lab number 1, where we are preparing with Dr. Lev a complex PTA and abdominal aortic. And I'll see you in a few minutes. So, Philippe, please play the video there and give me a couple of minutes to go to exchange to the other room. Bye-bye.
Bye-bye. Yes.